Stephen Trocha. I'm a surgical oncologist who works at the Greenville Health System in the Department of Surgery and has a co-appointment with the Cancer Institute here where I do surgical oncology. As to the question of why surgery, it's kind of complex. I guess that most of my life I've always been very good with my hands, and I've always enjoyed fixing things, whether that be in carpentry or engineering or doing electrical work or welding. My father was an engineer, and so I had a lot of exposure to sort of fixing and designing and making things better. I grew up in the country, so we had a lot of animals, and when your animals get hurt or injured, well, you don't usually take them to the vet, you usually take care of it yourself. And so my mother was actually the first person to show me how to sew. And so I used to have homing pigeons, and one of them had gotten injured once by a high wire, an electrical wire. And when he came home, my mom basically just grabbed him, flipped him over, and got some sewing thread and sewed him up and said, "Now you got to finish it." And so perhaps that was the beginning of why I was interested in surgery. Why am I excited about what I still do today? And I think one of the reasons I chose the track of surgical oncology was that it fulfills three really important things in my life. One of them is that I like doing very complex things. And in the world of surgical oncology, taking people's livers out, taking their pancreases out, reconstructing skin defects for melanomas, etc. All of those things are pretty technically demanding, and they require me to be really at the top of my game and to continue to evolve. So in other words, in order to be relevant today, I can't do what I did 15 years ago. So it requires me to continue to evolve the techniques that I use. And in the world of surgical oncology, that is just a never-ending development, if you will. So one of the reasons I would choose the profession that I'm in is because of the technical things that I get to do. The second is, and this relates more to the medical side of things, I enjoy seeing patients for short term, so for maybe a few visits and then having them be released so that they can go about their way. And I also enjoy long-term relationships with patients, so getting to know them over years and hopefully seeing them continue to live cancer-free. Now, clearly that's not always the case, but the opportunity to have short-term and long-term relationships is built into the world of surgical oncology. So I think that's also something that attracted me to that profession. And then finally, cancer is really a never-ending research question. So I enjoy doing research. I do both clinical research and I do a very limited amount of benchtop research. And when I mean benchtop, I mean really partnering with people who do molecular kind of benchtop. So in the world of research, cancer is unsolved, and I doubt it'll be solved in my lifetime, but that doesn't mean that we shouldn't strive to figure out different avenues of how to conquer cancer or overcome cancer or change the natural history of cancer. And so research being a very big part of what I'm interested in, I saw cancer as being one of those kinds of questions that would essentially keep me busy for my entire career. There is a variety of different problems or challenges that we face in surgery. And I'm sure there's a list that we could go on and on and on about. I can kind of think of two really important questions that we're currently dealing with. And those questions would be, I am doing a lot more robotic surgery and also laparoscopic surgery. And in that setting, what we're doing is we're using ultrasounds that are placed through tubes in your abdomen, what we call a port. And that ultrasound is then usually held in one hand while you're looking at the liver to see where there's a lesion or an abnormality. In my world, that's usually a metastatic lesion from colon cancer, for example, or hepatocellular carcinoma from hepatitis C or B that somebody has and that's affected their liver. When you're holding the ultrasound, what happens is it appears that you think that's a very static motion, that your arm is unwavering. But the fact of the matter is that you're trying to look at a screen, hold one instrument, and then put another probe or needle through the skin to coordinate it with the ultrasound image so that you can then destroy that lesion. And so what I didn't allude to earlier was that we're using the ultrasound to identify a lesion, and then we're doing that so we can target it with another device that helps destroy it, which we call an ablation. A little hard to appreciate, but when you're in the operating room, despite the fact that you're going through something of the abdominal wall, this is on a fairly long armature, if you will. So the entire ultrasound is up to probably 2.5, 3 feet long. And I think you can imagine that the further away you are from one end, any small motion gets translated to the other end in a rather large arc. And so it's not necessarily that it's shaking, it's that it just keeps moving. And if you're trying to target things with one hand and the image is moving with the other hand, you can imagine that that becomes a little bit more challenging to do. So one thing that would be very helpful is if the ultrasound could somehow be positioned or held in place, not worry about the image moving, and allow you then to coordinate really with two hands the probe going into the lesion that you're trying to destroy. Now, none of that really exists currently, and that might be an interesting area to pursue. Since I teach courses on ultrasound to other surgeons, and that's probably the most difficult thing they try to manage, which is using the ultrasound in one hand and then a targeting probe or the antenna that they're using to place in a lesion to destroy it. And trying to coordinate those two movements, despite being surgeons, is actually not that easy. Alternatively, one of my former partners, and I use that term loosely because he's really more of a mentor, was an individual who invented the PEG tube. And for those of you who aren't familiar with that, you might know it as a feeding tube. And so patients that wind up in nursing homes or who are towards the end of their life oftentimes will get a feeding tube since they can't eat themselves. That's really only one indication. They're used for a variety of other reasons. But that feeding tube is really a PEG tube, or what's referred to as a percutaneously endoscopically placed gastrostomy tube. So that's the acronym PEG. That PEG tube, which was invented by one of my former partners, as I mentioned, has really undergone very little re-engineering, if you will, since its inception. And while it is a very useful device, it is a little bit unwieldy in the sense that it's kind of like walking around with a long tail coming off of your abdomen. And it would be, I think, very advantageous to patients in order to figure out if there was a way in which we could change the character of the tube as it relates to the abdominal wall and the length of the tube so that it could become less obstructive or obtrusive to patients. We put these tubes in a lot for folks who have cancer, and while it's necessary and almost vital to their existence for nutrition, they accept that. When you kind of drill down on why or how things have been going, they will oftentimes relate to us that it's difficult to sleep, it's a little hard to run around with this tube, and if there were an opportunity to essentially redesign that, keeping the essence of what the tube represents, in other words, a way of entering through the skin into the stomach to provide nutrition. If we can maintain the essence of the device, but change the dynamics or the engineering of its relationship to the outside part of the abdominal wall, I think we could make a huge impact on perhaps quality of life for many of these patients. So as time has gone on, it's become very clear to me that partnerships are the best way for me to advance my career, but more importantly, how to advance my management of patients. And if I'm trying to offer them the best possible management, then I should get the best possible people in a team together. Those who have started to realize that the partnerships are the way to move forward, as, for example, in a multidisciplinary clinic, which is what we do surgically. Surgically, in cancer, we get together with radiation oncologists, we get together with medical oncologists, we get together with nurse navigators and radiologists, and we sit there and review cases and then subsequently decide what's the best treatment plan, as well as what is the best order of treatment. That is really a very small example, but a very pertinent example of how partnerships are the best ways of trying to figure out optimal management for patients. So if we do that within the world of medicine, why wouldn't we want to do it with external partners? External partners being those who do engineering, those who work within the pharmacy world, those who work within plastics, for example, or materials. There is a variety of relationships we could greatly benefit from. I've had an opportunity and a privilege to work with the Clemson Defined program for, I think it's almost 3 years now. And every group brings with them a very different set of sort of questions as well as interest level. I have yet to be disappointed by the students. I've always found them very engaging, very thoughtful, and to some ways very enterprising in trying to figure out how to change or accommodate some of the requests that I have. They are really being given a monumental task. They're being thrown into a world of clinical medicine, and in my world, clinical surgery, that for many of them they have no experience with. I think there's a lot of good in that, because when you come to things not really knowing much about them, that's oftentimes the first opportunity we get to look at something from a fresh set of eyes. And you've got to remember that if I've been practicing for 15 or 20 years, I have blind spots in the way I look at things. They're not intentional, they're just a function of the fact that I do something over and over and over again, and trying to see it with the eyes of a person who's 1 year into practice is different than when you're 20 years into practice. The process of working with the Defined students is never perfect. There's lots of stumbling. We bloody our nose almost on a weekly basis. But the advantages that come out of that are that we trip less the next time.